This is case L3 CT A74. The case history is a 51-year-old man with atypical chest pain 4 weeks following percutaneous angioplasty and stent placement in the distal left anterior descending coronary artery. We begin our analysis by first looking at a general inspection of the study. Here's the aorta, pulmonary artery at the base of the heart. As we move down, aorta appears to be of normal size. Left atrium also appears to be normal. Thoracic aorta, generally normal, all the way down to the bottom. We continue our assessment of the left ventricular function. Shown here is a horizontal long axis view, and here it is in motion. Here's the interventricular septum, apex, and lateral wall. Here is the vertical long axis, anterior wall, apex, inferior wall. Here is the short axis, septum, anterior wall, lateral wall, inferior wall. Wall thicknesses and wall thickening appears to be normal. The ejection fraction is in the normal range. We begin our review by looking at the left main coronary artery. This appears to be relatively short. If I switch to an anterior view, this otherwise appears to be generally normal, although there may be some very minimal disease in this area. We now begin review of the left anterior descending. Proximal portion of this appears to be normal. Here is the first diagonal. As we get into the mid-LAD, however, there appears to be some major issues. As we rotate around this area, it is clear that this represents significant obstructive disease. The second diagonal may or may not have any involvement. The stent in the distal LAD is clearly patent, as we can establish at this situation. However, even deblooming the area and reducing it to an MPR really does not allow us to have an adequate view inside the left anterior descending. We continue our coronary review, looking at the left circumflex. The proximal segment of the vessel appears to be generally normal. However, as we move down into the area of the obtuse marginal in particular, there is eccentric calcified plaque, and further down in the obtuse marginal, there may be some complex plaque, which appears to be at least borderline for obstruction. The vessel itself, however, remaining body of the left circumflex is very small and difficult to assess. We continue our review of the right coronary artery. The ostium appears to be normal. As we move down, we can see in the proximal segment there is some eccentric calcified plaque, non-obstructive. Further down, there also is some additional plaque, but rotation through the area suggests this to be non-obstructive. The remainder of the vessel can be brought out here. There is some minimal plaque at the crux, and then in the inferior distal portion of the right coronary artery, there may be some complex plaque in this area, mixed with calcified and non-calcified, but clearly is non-obstructive. Here is the posterior descending artery. I believe that this is generally normal. In summary, then, we have a 51-year-old gentleman who's had a PTA and stent placement, who now has a patent stent, although we're unable to see inside the stent exactly. There is clearly obstructive disease proximal to the stent in the mid-left anterior descending. There also is a likely obstructive lesion in the obtuse marginal with scattered diffuse but non-obstructive disease in the right coronary artery. The overall left ventricular size, shape, and function is in the normal range.